All right, let's get right into the Ankle-Brachial Index. This is a practical guide on how to perform it, understand the results, and use them in your day-to-day clinical work. Here's what we'll cover. We'll start with what the Ankle-Brachial Index actually is, then how to measure it, how to interpret the values, what to do based on those results, and finally, some limitations to keep in mind.
So first up, the fundamentals. What exactly is the Ankle-Brachial Index, or ABI?
Put simply, the ABI is a ratio. It's a straightforward, non-invasive comparison of the systolic blood pressure at the ankle to the systolic pressure in the arm. This ratio gives us a clear picture of blood flow to the lower extremities.
And why is this useful? Well, the ABI is our main tool for diagnosing peripheral artery disease, or PAD. It's a very specific and sensitive test for this condition, where arteries have narrowed and are restricting blood flow.
So who should we be screening? It's recommended for a few specific high-risk groups. Any smokers over 50, any diabetics over 50, and really all patients over the age of 70.
Okay, let's get into the practical side of things. How do we actually measure the ABI?
The process is pretty methodical. First, you'll measure the systolic pressure in both brachial arteries. Then you'll do the same for the dorsalis pedis and posterior tibial arteries in both ankles. For each of these 4 locations, you'll want to note the highest pressure reading. Now for the calculation. To get the ABI for each leg, you take the highest systolic pressure from that ankle and divide it by the single highest systolic pressure from either of the brachial arteries. It's important to use the highest brachial pressure to avoid a falsely low ABI, which can happen with subclavian stenosis.
So, you have your numbers. The next step is turning those values into a clinical diagnosis. Here is the most important takeaway number. An ankle-brachial index value less than 0.9 is diagnostic for peripheral artery disease. It's a clear cutoff. But of course, there's a whole spectrum of values. Anything from 1.0 to 1.4 is considered normal. Once you dip below that 0.9 threshold, the severity increases. A value under 0.5 indicates severe disease and requires an urgent referral to a vascular specialist. Now, what if you get a value that's really high, over 1.4? That's also an abnormal finding. It suggests non-compressible or calcified vessels. You often see this in elderly patients or those with long-standing diabetes, and it also warrants a referral. An abnormal ABI result isn't just a number, it dictates our clinical management plan. For any patient with an abnormal ABI, the foundation is cardiovascular risk factor modification. This means you need to be aggressive with smoking cessation and controlling diabetes, hypertension, and hyperlipidemia. Antiplatelet therapy should also be considered.
And your approach will depend on the severity. For mild disease with an ABI between 0.8 and 0.9, you'll start with risk factor management and lifestyle changes. On the other hand, severe disease with an ABI below 0.5 needs an urgent referral to a vascular specialist to see if revascularization is needed.
Lastly, the ABI is a great tool, but it's not perfect. We need to be aware of its limitations.
So, here are a few things to watch out for. As we mentioned, calcified vessels can give you a falsely high ABI. Also, if you notice a pressure difference of more than 10 millimeters of mercury between the 2 arms, that might suggest subclavian stenosis. And remember, the ABI is a screening tool, not the final word for all arterial diseases.
To sum it all up, the Ankle-Brachial Index is a quick, inexpensive, and reliable test you can do right at the bedside. It's an absolutely essential tool for screening those high-risk populations and getting objective data to guide your treatment.